Welcome back to the Ninja Nerd Podcast. Today we're continuing through our oncology playlist. Today's episode is going to be on colorectal cancer. We've got a lot to talk about, a lot of guidelines, a lot of screening, a lot of numbers we're throwing at you.
Yeah, it's tough, man. Honestly, when you look at all these guidelines, I mean, I think that's one of the tough things about, oncology is when you look at a lot of patients and you have to kind of screen and know what do you use to screen? What age do you screen? How often do you screen? That's a challenging topic. So I think we'll do that as a part of this lecture and every other kind of cancer topic that we discuss. But I think we should eventually have a podcast where we just talk nothing about just cancer screening guidelines. Really,
it will deserve an episode because it's just so important, and there really are a lot of numbers involved.
Yeah, a lot of different types of tests and a lot of different ages, a lot of frequency changes. So that'll be something that we'll discuss a lot in this episode, but we'll have another one where we talk about all of them and really trying to put them all together. But cool. Yeah, that's going to be a big thing, and I think that's the hallmark of what we talk about a lot in oncology is knowing really what is the particular risk factors, what is the age range that we should consider screening, what do we screen them with? Colonoscopy is going to be the gold standard. And then on top of that, it's also just noting what are the potential clinical manifestations that would make me concerned about colorectal cancer that I would go towards making a step like doing a colonoscopy.
Well, enough said. Let's get right into it here. We've got 3 cases. We're going to do an average risk, high risk, and a symptomatic patient. Let's get into it.
All right.
Well, we have 3 cases for today, and we're going to be going through each one. And hopefully you can try and get an idea and guess as we go through them.
We'll hit it.
All right, let's go. Case 1. So we have a 51-year-old male presents for his annual wellness visit. For his HPI, the patient feels well. He denies weight loss, GI symptoms, rectal bleeding, or fatigue. No personal history of polyps, IBD, or cancer. For his past medical history, hypertension, hyperlipidemia, and he's currently on lisinopril and atorvastatin. For his family history, negative for colon cancer. His exam, normal vitals, abdomen soft, non-tender, no rectal masses or occult blood. All right, Zach, we've got a 51-year-old male coming in for a routine checkup. To me, this seems like an average risk patient. There's no red flags. He's on top of his health.
Yeah.
He's just being proactive. So as the practitioner here with this patient, what are you thinking and how do you go from here?
Yeah, so this is an average risk patient. I'd say that this is a patient who is, there's no, like you said, personal family history. There's no inflammatory bowel disease. There's no symptoms. And so with that being said, I don't think that we need to be going earlier. So oftentimes we kind of keep the range of when we would screen these patients at the age of 45. So greater than or equal to 45, you'll start screening them with a colonoscopy. And the whole point of that is to go up and see, hey, is there any polyps? Is there any kind of like weird looking polyps? Is there any colorectal cancer in general that may be kind of like at this point in this patient asymptomatic? So that's something that we try to do to prevent from finding it at a stage 4, stage 3 level. So this patient, I would just recommend, according to the USPSTF, at this patient, 51, they should definitely get a colonoscopy sometime very, very soon since they're definitely overdue at this point. Age 45 or greater, start with a colonoscopy. And then from there, we usually do it like every 10 years.
Okay. And at that point, if it's normal, it's just every 10 years, right?
Yeah.
Okay. Well, if you had to choose, what's your go-to screening method? Is it the colonoscopy?
Yeah, the colonoscopy is really the go-to. The reason why is there's different types of things that you could do. You could do like the flexible sigmoidoscopy. They don't really do that except in patients who have what's called familial adenomatosis polyposis because those patients are almost always left-sided disease. So they usually get thousands upon thousands of polyps that occur in like their rectum, their sigmoid colon, their descending colon. But in patients who have colorectal cancer, it can occur anywhere from the rectum all the way to the cecum. And so we need to be able to evaluate that entire large colon. So that would be the go-to is the colonoscopy. And again, for this patient, since they're average risk, I'd start at the age of 45 or greater, which this patient's definitely overdue. And then if it's completely normal, usually we just go every 10 years.
Yeah, so in our patient, let's just say he is normal. So he's 51 now. So he would be due then for another colonoscopy at age 61.
Yeah, assuming everything was like perfectly normal.
And it was.
Yeah. I think the other thing here is there is alternatives. I think it depends on the patient. So for example, if a patient was like, I don't really want a colonoscopy, you could check for blood. So sometimes a lot of the times when patients have colorectal cancer, specifically, I'd say right-sided colorectal cancer, it's occult bleeding, meaning that you don't see it. So you poop and you don't see any blood in the poo. It's usually mixed in with the stool so you can't actually visibly see it. So with those patients, they're not coming and saying, hey, I have blood in my stool. So with those, we can do what's called a fecal occult blood test. It literally just tests for blood in the stool. Or you can do a FIT test, which is like a fecal immunochemical or immunohistochemistry test. And it's a little bit better at identifying proteins like hemoglobin, which is a part of blood, or red blood cells. So Those are things that you can do yearly. And if you ever get an abnormal FIT or fecal cold blood test, then you tell the patient, hey, I'm concerned. You may have something that's bleeding in your colon and it could be cancer. Let's do a colonoscopy. So if they prefer, I don't want to do a colonoscopy, you could say we could do FIT testing or fecal cold blood testing every year. And if it comes back abnormal, we gotta do a colonoscopy. Yeah, the other alternative is CT colonography. We don't really do this one that often, but this one is basically, it's an image. So it's not like a little poop test where you kind of take poop and you literally put it on and say, is there hemoglobin in the FIT test or blood in the fecal col? This one, we actually do an image. We do a CT scan with contrast, and that kind of really gives an image of what's going on inside the colon, and we can see, oh wow, there's a big polyp, there's a mass, there's an abnormal appearing lesion. At that point, if that's abnormal, you got to go get a colonoscopy, because we got to figure out what that is. We need to biopsy it potentially and figure out a little bit more about it. If it's normal, then you can just keep doing it every 5 years. So again, alternatives is a FIT or a fecal cold blood test. You can do that yearly, or a CT colonography every 5 years. But if any of those come back abnormal, you have to get a colonoscopy. It's the gold standard.
Let me float a different scenario your way. So our patient now, he was good. He had no issues, and now he should be due for another colonoscopy in 10 years.
Yep.
If he had elected for that. Now, let's say he different scenario. Let's say now that you actually do his colonoscopy.
Yep.
All right, he's 51, and now you find 2 small tubular adenomas.
Okay.
Does it change the 10-year rule?
Yeah, so then in those patients, so there's a couple different reasons of why we would go to a sooner time. So this is where if it came back abnormal, we can say technically, according to like the guidelines, you can say I could go every 3 to 5 years. Well, how do I know if it's 3? How do I know if it's 5? So 3 years would be if it looks like if they have a bunch of them, like 3 or more. If when you look at them under the microscope, they have villous features, which is kind of like villous, remember villain, that's bad. That's a bad type of adenoma. And the last one is if it's a lot of dysplasia. That means that high-grade dysplasia, super, super high risk of it kind of converting over. So in those, we got to go sooner, because that means there's a high chance of it turning into cancer. So I'd probably go 3 years. But in a patient who has like, they don't have any villous kind of like adenomas, they don't have like more than or equal to 3 adenomas, they don't really look like there's high-grade dysplasia, I'd push to go at 5 years. So that's what I'd probably do for this patient is they have 2 small tubular adenomas. There's no evidence of any high-grade dysplasia. I'd probably go at 5-year range.
And then any more than 2, probably saying 3 years.
Yeah, greater than or equal to 3, high-grade dysplasia, villous features on microscopy, I'm going sooner.
Okay.
Yeah.
All right. Well, that wraps up case 1.
All right.
And let's move on to case 2.
Hit it.
So we did an average risk patient. I think you can probably guess where we're headed with this one. So we have a 38-year-old woman, presents for evaluation due to her family history of colorectal cancer. She's asymptomatic but concerned. Her father was diagnosed with colon cancer at age 45. She currently is presenting with no rectal bleeding, anemia, or change in bowel habits. She has no past medical history. She's not on any medications. For her family history, as I just stated, her father was diagnosed with colorectal cancer at age 45. Also, her paternal aunt was diagnosed with endometrial cancer at age 48. It's a little interesting, huh?
Yeah.
All right. For her exam, vitals are normal. Rectal exam is deferred. Asymptomatic.
Okay.
So, Zach, we have a different one here.
Yeah.
Strong family history. Patient's concerned. She's only 38, but her dad had colorectal cancer at age 45.
Yeah.
Does she qualify as an average risk or a high risk?
Yeah, it's definitely high risk. So any patient where they have colorectal cancer and a family member before the age of like 60, in this case they're at 45, that's pretty concerning. And then on top of that, they had another family member with endometrial cancer, which is kind of odd. So you can always remember, I remember the mnemonic CEO in colorectal cancer. So CEO is colorectal cancer, endometrial, ovarian cancer are almost always associated with Lynch syndrome for your exams. And so that's one thing that gets me a little bit concerned. Now, Lynch syndrome, I have to go through a bunch of different kind of like genetic testing to really figure that part out. But at least right now, I would consider this patient high risk. I can't diagnose them with Lynch syndrome yet. I'd have to go a little bit further with that one. But when we look at high risk, the earliest way that we can like do a colonoscopy or a scope on this patient sooner is we would say we would start earlier than 45, at least age 40. But we could also make the argument to say they had a family member who had colorectal cancer at the age of 45. That's when they were diagnosed. We could even make the argument to say that we can go at the age of 40 or 10 years earlier than the family member who was diagnosed.
Okay, so 35.
Yeah, and so that would actually make me, and it's whichever one is sooner. So whichever one comes first, that's the time that we would actually do the scope. So in this patient, I would say at 35, that's when they should have technically have gotten a colonoscopy. So that's when I would say absolutely, this patient definitely should be getting a colonoscopy. They have a family member with colorectal cancer at a young age. That really suggests a hereditary cancer syndrome. And that's what I'm thinking about is Lynch syndrome. And Lynch syndrome, technically, you should be, if you have a diagnosis of Lynch syndrome, you should be getting scanned way earlier. Dude, I'm talking like 20 to 25 years of age. That's when they're scanning these patients, or scoping these patients. So with this one, for sure, they have colorectal cancer in a family member less than 60. That's definitely high risk. And on top of that, they even have another family member with endometrial cancer, screams hereditary cancer syndrome. So we either go at the age of 40 or 10 years earlier than the family member who was diagnosed. And so, yeah, I think that falls right in there at the age of 35. If they're 38, we should do a colonoscopy as soon as we can.
All right, so she's due now. We're a little concerned with Lynch syndrome. So tell me a little bit more about Lynch syndrome, because it's colorectal cancer, but it's hereditary.
Yeah, so usually these are patients who have a mutation in the mismatch repair genes. So these are genes like, for example, imagine these genes. So every time we have one cycle of DNA replication, you always get insertion deletion errors. It's just natural. It's a part of the replication process. That's why we have mismatch repair genes to fix those mess ups. Whenever you have a mutation in those genes, those mismatch repair genes don't fix the damaged DNA. They don't fix those insertion deletion errors. Now, that happens a little bit, but as that starts to accumulate and accumulate and accumulate over time, that leads to mutations in very critical genes that control growth. That's what happens in this disease. And so they probably have a mismatch repair gene mutation, and there's a bunch of different types of them. But what happens is when those mutations accumulate over time of every single time having a mismatch from the DNA undergoing a replication, that's going to lead to the incidence of a normal cell turning into a tumor cell. And those tumors tend to just form in three particular areas: the colon, the endometrium, and the ovaries.
So just to make sure I have this correct, I just want to clarify. I'm not sure if I'm understanding this correctly.
Yeah.
So with colorectal cancer, is this meaning like those two things are connected?
Yeah.
Or like Lynch syndrome is commonly manifesting in those locations.
Exactly. So
okay.
Lynch syndrome can manifest in colorectal cancer, endometrial cancer, and ovarian cancer. It's going to be more common to be colorectal, but you can see them potentially at all three of those locations.
And that is maybe what happened to her aunt, was saying that she probably had Lynch syndrome, but hers manifested endometrial.
Yeah, exactly. So it's kind of scary, and that's why usually with these patients, not only are you kind of like doing a probably earlier surveillance for just colorectal cancer, you're probably also doing that earlier for ovarian cancer and endometrial cancer. So those are definitely concerning features there. So that's what I'm thinking. I'm thinking that this patient probably has Lynch syndrome, given the family history of a very early disease, right, in the father, and then on top of that, an aunt that had endometrial cancer. That's concerning me. So usually what we would have to probably do is get a colonoscopy. We should do one right now. And then also we should test. We should do an immunohistochemistry test for those mismatch repair genes. So once we actually go in and we find the tumor, here's the polyp, here's the tumor, take that, send it off to the lab for an immunohistochemistry study to look for any mismatch repair gene proteins or mutations that are present. That's probably what I would do with this patient if we had that scenario.
Let's just say we have the perfect situation, a textbook patient here. Let's say, for just argument's sake, she's 20 years old. Mm-hmm. In a perfect scenario, textbook-wise, you had briefly mentioned it before, but what's the actual screening for that? It's colonoscopy. Let's just say she's age 20. So how would you do that if you're a textbook case and you're being very proactive?
I mean, you could start at age 20 or 25. It kind of is anywhere between that age range. But you're just going to be doing that every 1 to 2 years.
1 to 2, okay.
Yeah, so you're going to be good. Probably, honestly, with most patients, they're probably going to err on the side of cautions as a clinician, and they're probably going to go annually.
I would hope for that.
Yeah, so 20 to 25, you're probably going to be going every 1 or 2 years and getting a colonoscopy, just looking to see if they have any of these polyps that are forming. Usually, the problem with Lynch syndrome is it doesn't make big polyps. So usually what happens is when you have Lynch syndrome, it starts off with a mutation, right? And that mutation in the mismatch repair genes, the epithelium gets a little abnormal, but it doesn't make any hyperplasia. It doesn't actually start proliferating a lot. And so usually what happens is patients will get an early adenoma, and then they'll get a late adenoma, and they'll get these big polyps, and then that'll turn into cancer. With Lynch syndrome, you actually can get adenomas, but they're flat. or they're sessile, so you can't really see them. They're not popping off of the surface in the colon mucosa. So guess what? As you're going through and you're looking to see if you can find a polyp. In Lynch syndrome, you don't often find these big polyps, and so they can kind of easily be missed. And guess what? Next time you go back and you do a scope, guess what you're going to find? A carcinoma.
Yeah.
And so these things are very rapid and very aggressive. So that's one of the things about colorectal cancer and Lynch syndrome is that they can have these flat adenomas that you can't, or they can be very sessile and you can't see them. And then you come back a year later and all of a sudden they've rapidly grown into a big tumor.
You mentioned this in the first case, but how about other syndromes like FAP?
So FAP is a scary one, really, really sad. These patients almost 100% chance that if they are by the age of 40, they'll have colorectal cancer. So that's a massive, high rate of developing colorectal cancer. So it's a mutation in the APC gene. And this APC gene is basically, it's a gene that controls the proliferation, right, of cells. And so they have this mutation, and basically what happens is they can't break down this protein called beta-catenin.
Say that again.
Beta-catenin. So beta-catenin usually, unfortunately, builds up, and then they get this uncontrolled cell growth. And that usually causes this cell growth to occur in the form of polyps. And they get, I'm talking thousands of polyps, buddy, thousands. And so, but usually by the age of 10, 12, they have maybe hundreds to thousands of polyps in the left side of their colon. And so the chances of any of those polyps then converting into a carcinoma is very, very high, with an almost 100% chance that they'll develop colorectal cancer if it goes untreated by the age of 40. And so if that happens, and unfortunately with familial adenomatosis polyposis, or FAP, we say we'll start off screening these patients with a colonoscopy at the age of 10 to 12. And we're going to do it every year, but the ultimate goal is we're just doing it until we can get to the point where we can do a colectomy. We're unfortunately going to remove the entire left-sided segment where they can form colorectal cancer and just prevent that in all. Because again, there's almost 100% chance. And so we're going to do a prophylactic colectomy. It's just timing. When should we do it? Well, until we do that, annually they're getting a colonoscopy starting at the age of 10 or 12, and you're just going to keep doing it. And at any point, we need to try to get them to a prophylactic colectomy.
That's incredibly unfortunate.
Yeah.
You have to have a colonoscopy at the age of 10.
I know. That's pretty sad. Pretty sad. But that's the problem with hereditary cancer syndromes, is that FAP is a really big one. Lynch is a really big one. There's other ones. I don't want to go into crazy detail on them. There's one called Peutz-Jeghers. They like to ask us on the exam. The only thing I would say on Peutz-Jeghers is they get a bunch of polyps, and they can occur anywhere: stomach, small intestine, large intestine. So that's kind of odd because it can cause colorectal cancer, but these polyps can form anywhere. And they're these big adenomatous polyps. But if they ever present a patient in the vignette, it's going to be a patient who has polyps and that look very large, and they have all these hyperpigmented lesions around their lips, on the actual, sometimes they're going to occur on the tongue and on their hands and feet. So anytime you see that in the vignette, think Peutz-Jeghers syndrome. And sometimes you can even get kids who can just get a bunch of polyps before the age of 5 too. And that's called juvenile polyposis syndrome. They don't usually ask as much on that one, but they do ask on Peutz-Jeghers. So remember, bunch of different pigmented lips, tongue, hands, feet, and a bunch of big polyps in the stomach, small intestine, large intestine. Think Peutz-Jeghers. But these are the hereditary ones. So that's really important to remember: is FAP, Lynch syndrome, and I'd say Peutz-Jeghers.
So during this podcast episode so far, we've discussed an average risk patient and a high risk patient, both of which who were non-symptomatic.
Yep.
They were asymptomatic.
Yep.
They were good to go.
Yep.
Well, what happens now if we talk about a patient coming in with symptoms? Let's find out. We have a 62-year-old male, presents with fatigue and shortness of breath on exertion. Symptoms have been gradually worsening. He denies chest pain or cough. However, he reports new onset constipation and mild abdominal cramping. He has visible blood in his stools, and now he is also stating that his stools are narrower than usual. That's an odd finding, right?
Yeah, if I saw some pencil-shaped stools, I'd probably be scared too.
Yeah, me too. I
just pooped out a number 2 pencil, Rob.
Yeah. Anyway, his past medical history: type 2 diabetic, GERD. Medications he's on is metformin and omeprazole. He has no family history. For his exam, vitals: heart rate is 96, blood pressure is 124/78. General, he looks pale. He's fatigued. He just doesn't look himself.
Okay.
Abdomen: mild left lower quadrant tenderness. No mass felt on palpation. Zach, this patient comes in with changes in bowel habits and hematochezia.
Okay.
What are we thinking here?
Yeah, I mean, when I think about this patient, I'm definitely concerned about colorectal cancer, because the changes in bowel habits are concerning for a left-sided kind of colorectal tumor, and then also hematochezia. So Here's what you want to think about. Whenever you have a patient coming in and they're complaining that they have things like a pencil-shaped stool, they have periods of where they're constipated, but then they have periods where they have diarrhea, and they feel like they feel this urge that they have to go to the bathroom right after they just went to the bathroom, and then they have blood in their stool, you should have a very high degree of suspicion for colorectal cancer, probably on the left side. Because when you think about this one, colorectal cancer can occur on the left side and the right side. So that's how we kind of define them generally. It's easier to do that for organization sense and memorization. But left-sided colorectal tumors, which is actually the more common presentation, probably 85% of cases occur there. Usually what happens is when you get a tumor there, imagine you have here, like let's imagine you got your descending colon here, sigmoid colon going into the rectum, and you got a tumor like right in the sigmoid colon of the rectum. Well, poo is at this point coming down, it's going to be solid. It's going to run into a roadblock. And that tumor, that where it's in the sigmoid colon of the rectum, is obstructing the flow of poop out into the toilet bowl, hopefully. And so what happens is as it runs in, it hits that roadblock. Let's imagine that it's not a complete obstruction. Well, what's going to happen? Some of that solid poo is going to squeeze through that stricture. And when it squeezes out, what's it going to come out looking like?
Number 2 pencil.
Yeah.
Hey,
it's
you made the comment.
Yeah, but like that's how they probably get that. The second thing is when the poo hits that stricture and it gets stuck there. Let's say that some of it squeezes through, and some of it could even be liquid. That's why they probably can get diarrhea. But when they get through, now that poop is stuck above it. That's where the constipation comes in. So they have periods where they don't go for a couple days, and then they have liquid that squeezes around it. So that's where they get the diarrhea. But the other one, which is really important, is if you have a poo that's stuck right above the obstruction, what's going to happen to the colon above it? It's going to start dilating and dilating and dilating, and that's where you get that abdominal pain, because as it dilates, your natural response is, I got to expel this sucker. So then the colon tries to contract down on it, and it dilates and it contracts down on it. And so that's where they get that colicky abdominal pain and the feeling that they got to go to the bathroom. But every time they go to the bathroom, I'm not pooping anything out, and if I am, it's like a little pencil, or I have little bits of diarrhea. That right there is super concerning, and if I see blood, that means that tumor is probably bleeding, and it's kind of causing blood to coat the outer parts of that stool. So that right there is super concerning for a left-sided colorectal cancer.
Let's say we got blood work. What kind of blood work would you be interested in doing for this patient?
Well, I'd say like for this one, I would probably start off, well, first, let's say that I saw the blood. Okay, that's good. I always like to make sure that it's actually blood. So I'd probably do a fecal occult blood test or a FIT test just to make sure.
Okay.
You don't have to, but I would. Just to make sure, hey, whatever's coming out that looks and appears to be blood, is it blood? Mm-hmm. The other thing I would do is I could get like a CBC if I really wanted to confirm that they have anemia, but I wouldn't say that that's going to be completely necessary. Now, here's the other caveat. So left-sided colorectal cancer, usually it's visible blood.
Yeah.
And then they have bowel habit changes. Right-sided colorectal cancer, and this is not that patient, but if they had right-sided colorectal cancer, you probably wouldn't even know. They wouldn't have visible blood. They wouldn't have changes in bowel habits. The reason why is in the ascending colon, the cecum, transverse, it's a really gargantuous lumen there. The lumens are pretty big, and also the stool that's running through there isn't solid. It's more liquidy.
Yeah.
And so when that happens, if there's this tumor, which is usually in the let's say in this case, the right-sided part of the colon, it bleeds, it mixes with the liquid. And so by the time it gets out, you don't really see it. It's not invisible.
Okay.
And so they have slow chronic blood loss. Slow chronic blood loss always equals iron deficiency anemia. So if I had a patient who came in and they didn't really have a lot of symptoms, but they were like fatigued, they were like kind of a little bit, pallor, or they felt really exhausted, and they were greater than 50 years of age, I'm probably going to get like a fecal occult just to make sure because I don't see it.
Yeah.
But is it there?
Yep.
Second is I can confirm it with a FIT test, which is just a little bit more accurate because that's hemoglobin, not the blood. And then from there, I'd probably get a CBC. I'd probably check and see, do they have a low hemoglobin? Is their MCV low? Check their ferritin, their iron, and their transferrin saturation to see if those all suggest iron deficiency anemia. So that's probably what I would do in a patient who came in greater than 50. They got some like weird like symptoms, just vague, general like fatigue, pallor, weakness. I would check. I'd just make sure I'm not missing that. And then if I found that, I would say that patient deserves a colonoscopy, just like this patient who we have changes in bowel habits and blood in their stool. They deserve a colonoscopy right now.
And then overall, the major difference between left and right is really saying left, you're having visible blood in your stool. Mm-hmm. Right, you're just not able to see it.
Yeah, exactly. It's a occult GI bleed.
Okay.
Yep.
All right. Well, we have a good little difference now between left and right-sided masses.
Yeah.
So let's say now we want to go to the next step. It's a diagnostic colonoscopy, and most likely with a biopsy.
Yeah.
So our patient, we get a colonoscopy. It shows a large left-sided mass. Biopsy confirms adenocarcinoma. So now that we know what's going on here, we have it basically diagnosed. What's our staging approach?
Well, we got to make sure it didn't spread anywhere. So that's probably the first thing I would do is I'd do a full pan CT scan. And so I'd do their chest, I'd do their abdomen, their pelvis. Because with colorectal, it likes to spread to a couple different areas. Usually the most common one is the liver. So it's almost always going to spread to the liver. You're going to get liver mets pretty quickly. It can spread to the lung, I'd say the next one, and they can spread to the peritoneum. The brain is probably the less common one, but if a patient came in seizing, they had headaches, like uncontrollable, like weird headaches, they had focal neural deficits, and I know that they have colorectal cancer, I may get a brain CT or an MRI just to make sure that I'm not missing that it spread to the brain. But oftentimes you're at least going to look for the liver mets, lung mets, and so usually I get a CT of the chest, abdomen, and pelvis. And if I find any of those, that really helps me to look to see if these things have spread anywhere to the lungs, to the liver, and to the peritoneum. Because if it does, they're now stage 4 colorectal cancer.
Meaning you have mets.
Yeah, exactly. The other thing that we don't do it to diagnose, and this is really important, I'm going to say it again one more time. We don't do it to diagnose colorectal cancer. We do it to determine how well they're responding to therapy. We check a CEA level. It's a carcinogen embryonic antigen, and it's basically it's a molecule it's a tumor marker that is secreted by colorectal tumor cells. And whenever it's secreted, we kind of look at the number and say, oh, wow, that's really high. Okay, well, it doesn't tell me how, it may kind of give you some of an inclination of how bad their colorectal cancer is, but that's not perfect. All we know is we look at their CEA level as a baseline. So let's say that we diagnose them with colorectal cancer, they have mets, we get a CEA level, it's super high. We don't use that to diagnose it. What we do is when we get to the point where we have to do a colectomy or give them chemotherapy, we track the CEA level.
Got it.
So, hey, this was their baseline of like whatever this number is. We gave them, we did a colectomy and we hit them with some chemotherapy afterwards. What's their CEA level now? Oh, it went completely down, super low. That's good. They're responding to therapy. If we were doing all these things and their CEA levels are still really high, okay, is this not working? Or later on, when we check them and they're kind of like maybe they're in remission, their CEA levels are really, really high all of a sudden. Oh shoot, do they have like relapse? Are they no longer in remission? So it's really helping us to determine the effectiveness of therapy, and kind of it just uses a baseline right up front.
Okay.
That'd probably be the big things. I think when we already talked about, like when we had that patient who had Lynch syndrome.
Yeah.
When we did the colonoscopy and we do a biopsy and we take that tissue, we can send that off to make sure that it doesn't have any mismatch repair gene kind of mutations. We can use that as well. But I'd say the biggest thing is look to see if it's spread anywhere. And then second, get a baseline level of what their CEA is. Those would be the two things for sure.
Well, let me hit you first with the CT.
Okay.
CT shows no distant mets, but +2 regional lymph nodes. With that being said, with that information I gave you, what's the stage?
All right, so I try to make this one super easy for colorectal cancer because there's always these T&M staging, and it's really annoying. Stage 1 and 2, it's a tumor, and so stage 1, 2, you have a tumor, but it hasn't spread to the nodes. Stage 3, it's in the nodes. Stage 4, it's mets. So there's stage 3 right here because they're in the nodes.
Node positive, no distant mets.
Yeah, exactly.
So what's treatment then?
For stage 3 for these patients, we'll still try and do a colectomy for these patients. But you may try to do chemotherapy to shrink it down a little bit before. So you may do some neoadjuvant chemotherapy with there's these regimens. We always have abbreviations, like you've noticed in oncology, like ABVD, B-CHOP, R-CHOP. They're all over the place, right?
It's in medicine, like overall.
Yeah.
Every episode.
But this one is tough because, again, with this one, we can use like Folfox, which is a different type of we use like 5-fluorouracil, oxaliplatin. There's a bunch of different drugs that we can use in these. Or FOLFIRI. And so we can use a bunch of these, but it's usually we're going to use these medications or these chemotherapeutic agents prior, maybe as a neoadjuvant, shrink the tumor down, and then see if we can cut it. Some patients will just go straight to colectomy, and maybe we'll do it adjuvantly. But you're probably going to get a combination of those two, which is the colectomy. See if you can remove as much of that potential tumor of where it is. In this patient, they had a pretty decent sized one. So we'll cut that tumor out, see if we can anastomose the ends. And then on top of that, maybe do some chemotherapy afterwards to eliminate any micro metastasis, because you're trying to cut the tumor out, right? But if you just happen to have a margin that's a little bit beyond that, then the chemotherapy can come through and help to kill any of those micro metastasis.
Yeah, rather be thorough.
Yeah, exactly.
So let's just, another hypothetical for you here, Zach. What if it were stage 4 and this patient had isolated liver mets?
Oh, okay. Well, that's it. So technically stage 4, technically, you don't do any surgery. The only time where there's like this like theoretical thing is if you only have like a couple liver mets. I'm talking like, and they're actually resectable. So liver, I told you, is the most common site of metastasis. If you look and they got like maybe 1 or 3 liver mets, and there's not like, I'm talking tens, hundreds, a bunch of them all in the liver, you can technically still do a colectomy. You can still do chemotherapy, and you can do what's called it's a weird term, but it's a metastectomy. So you're cutting out those mets. You're removing the mets in the liver as well. But you only do it if you got like maybe 1 or 2 potential mets. And so theoretically, stage 4, you can consider a colectomy and then resection of the mets and chemotherapy, but it's only if they have like a couple like mets in the liver that are very easily accessible and I can get rid of them.
So they truly are isolated. There's not many of them.
Yeah, I think that would be the only thing. Otherwise, you don't really do surgery. You go straight to what's called a targeted therapy, where you kind of look and see, I actually have to figure out, do they have any of these weird mutations? And so then I'd have to test and see, do they have that MMR, the what's called mismatch repair gene mutations with a high instability? If I do, I use a special drug.
Yeah.
Do they have this KRAS or BRAF mutation? Oh, if they do, I have to use this special drug. Do they not have a KRAS and BRAF mutation? I got to give this special drug. And so those are the only times, and we'll oftentimes just do chemotherapy potentially with those targeted therapies.
All right. Those were our 3 cases, all wrapped up and done, but I think this kind of warrants a nice final high-yield recap.
Yeah.
Just going over our average risk, high risk, symptomatic, and then some staging.
All right. So I think, again, average risk, I think the biggest thing to remember is that we start doing colonoscopies in patients who are average risk at the age of at least greater than or equal to 45, and we should be doing them every 10 years if it's completely normal. Your goal is to do this just to make sure that you're catching a cancer before it's too late. That's all it is. And again, you're doing this in patients with no personal, no family history. There's no hereditary cancer syndromes. They don't have inflammatory bowel disease, anything like that that puts them at high risk. For the high risk patient, this is the one who has a personal history, has a family history where they have a direct first degree relative who had colorectal cancer or some other kind of associated cancer syndrome less than 60 years of age. They're greater than 50. They have a lot of these risk factors, and those high-risk patients, we got to do it sooner. So, for example, in general, with a family history or personal history, we go age 40 or 10 years before the first-degree relative was diagnosed with that type of cancer. If they truly have a diagnosis of FAP, you go 10 to 12 years of age, and you do it every year until they get the colectomy. If they have Lynch, it's 20 to 25, and you do it every 1 to 2 years, and hopefully you'll catch it before it's too aggressive for these patients. So that's your high risk. Yep. The other one is patients who come in symptomatic. Again, I like to separate them into left and into right. So left-sided tumors, they're going to present with the changes in bowel habits, the tenesmus, the constipation, the periods of diarrhea, the periods where they have hematochezia as well. They feel this urgency that they have to go and poop, but they can't. Those are all concerning features of a left-sided tumor. A right-sided tumor, usually it's occult. You won't know it. So this is a person who's a little bit older. They have iron deficiency anemia. Maybe they present with fatigue, with pallor, and their CBC and their fecal occult blood test comes back showing it's abnormal. Those are patients which I'm going to want to screen sooner. So I'm not sooner, right away, because I want to get a colonoscopy as soon as I possibly can for these patients. Once I've done these things, so let's say that in any of these patients I've done a colonoscopy, I found an abnormal appearing mass, biopsied it, confirmed that it's an adenocarcinoma of sorts. Then we have to say, okay, they're diagnosed with it. How advanced is it? I'll use CT, chest, abdomen, and pelvis to figure out if it's spread anywhere else. And based upon that, I can even see if they have lymph node spread. If I have a patient who has a tumor, but they have no node spread, it could be stage 1, could be stage 2. Usually stage 1, you can just resect it. Pretty good. Stage 2, you can probably just still resect it, but you may use a little bit of chemotherapy like FOLFOX or FOLFIRI. Stage 3 is this is now in the nodes. So now we definitely have to do a colectomy and we have to do chemotherapy. And then stage 4, this is mets. You got it in the brain, you got it in the liver, you got it in the lung, you got it in the peritoneum. And those parts, we do chemotherapy, but we also target. So we do specific targets. And that's where I was saying, If I test what's called the MMR mutation and it comes back positive and they have a high degree of instability there, we use something called PD-1 blockers. It's called pembrolizumab. That's a newer thing that we've been using. If they have no KRAS or BRAF mutation, in those scenarios, we can use something called an EGFR blocker, which is an epidermal growth factor receptor blocker like cetuximab. That's kind of a newer one. And then the last one is if they have a KRAS or BRAF mutation, then we can't target the KRAS. So we use something called a VEGF inhibitor like bevacizumab. And so those are things that we can use as targeted therapies if they're at the stage 4 level. But this kind of scenario here, I think it's just overall the big thing to take away from it is know when you screen for average, know when to screen for high risk, and know when to identify concerning features of colorectal cancer. And then know, okay, if they want to do this, colonoscopy is the gold standard. But again, some patients, they're not a fan of it. So what are the alternatives? FIT, fecal occult yearly, CT colonography every 5 years is an alternative that you can consider as well. Either way, if those are abnormal, get the colonoscopy. Colonoscopy comes back abnormal. You need to determine, is it cancer or not? If it is cancer, okay, what do we do? If it's not cancer, but it's abnormal, we got to go sooner. But if it's completely normal, then you may be able to span these colonoscopies out a little bit further.
I feel like as we go through each episode in oncology, it's just a recurring theme. How important it is for screening and to know when to screen.
Yeah.
It just seems to be a recurring theme, and especially with something like colorectal cancer, that you would agree it's just kind of silent.
Yeah, that's the tough thing. And it's just like the next one we're talking about is prostate cancer. Guess what? Prostate cancer is almost 80% of cases completely asymptomatic, silent. You can't diagnose it. Usually it's unfortunate.
Yeah.
By the time they present, they're usually maybe at a more advanced stage. And so I think that's one of the important things. And that's why I think eventually we'll have a podcast where we talk just about the screening guidelines just for cancer, because there's so many and there's so many different numbers and age ranges and how do we do it here? When do we do it there? And so I think one of the best things is to talk about those as a collective, which I think we'll do.
I think that definitely deserves an episode.
Yeah, exactly.
Awesome.
Exactly.
Well, but thank you. And that was a great episode, jam-packed as always, but a lot of fun.
I really hope that we're helping you. I hope that whenever you have some spare time, whether it's doing some laundry, running an errand, whatever it may be, I don't know, you're at the gym working out and you just want to listen to us, I hope that you guys are learning a lot. I hope that you're enjoying this. I hope that you're able to understand this topic a little bit more. And I hope that we could just make a little bit of a difference in your day. But thank you so much. I really hope that we brought some awareness as well to colorectal cancer and how important it is to be able to know when to get screened, when to get a colonoscopy, how frequently, who are the patients that are at very high risk, and then when to notice potential symptoms that are concerning. So I hope that you guys learned a lot. I love you guys. I thank you guys so much for being so awesome. And as always, until next time.